Alright, good morning. This video is about last week's presentation that I owe you, and I'm just gonna jump into it and start from slide number 6. We're talking about exercise as medicine. I don't think that it's a new idea. I think that it has been a while since things were worded in such a way to actually say those words, exercise is medicine. And yes, exercise is medicine. Anyone from the exercise field, exercise sciences, exercise physiology, clinical exercise physiology, knows that exercise is medicine, meaning that exercise is part of the treatment. It has to be, for the vast majority of conditions and diseases, part of the solution, and it should be taken into consideration by all of the people, the professionals involved, and of course the patients. There are very, very few conditions that exercise might not be a good idea. We won't go over them, but that's generally the whole idea. We know very well that when you add exercise to a treatment plan, when you add exercise to the recovery plan, when you add exercise as part of the rehab plan, it starts a circle of stimulus and response that we've talked about that principle, and there's starting to be a co-relationship between the exercise to the medications that are taken and the treatments that are given, and vice versa with the exercise. So it goes back and forth, and it's really important for physicians to understand that, and for physicians to be able to communicate with one's clinical exercise physiologist and to discuss such things. It doesn't have to be every week, but there should be that open channel and understanding with physicians that a clinical exercise physiologist might approach them regarding a client or a patient of both of them to try and adjust medications and treatment and so on and so forth. When that happens, preferably, with other professionals as well, such as nutritionists and so on and so forth, the client slash patient gets the best outcome possible, and all the aspects of treatment are dealt with. When we're talking about exercise, I think that the major word that we have to understand regarding exercise is adaptation. Why do we exercise? Because we want to enjoy the adaptations that come with it. Well, excuse me. And that is something that we definitely want. So the word exercise and adaptations come together, and using that word, we can understand that we can adapt different lifestyles. We can adapt changes to medication and treatment and so on and so forth. So I'm looking at page 8, and I'm just kind of scanning to see if there's any point that hasn't been discussed. Okay. Alright, so right now I'm looking at slide number 10, and I just thought that it'd be interesting to bring a few of the definitions or sub-definitions of medicine. And the first one is a substance or preparation used in treating disease. Interesting, right? Or something that affects well-being. In both cases, you can find exercise in there. In slide 11, we're talking about the science and art dealing with the maintenance of health and the prevention, alleviation, or cure of disease. You can find those components, all of them, in exercise. Then we have the branch of medicine concerned with the neurosurgical treatment of disease, non-surgical, sorry, treatment of disease. We are non-surgical, so we're in there as well. And then you can see a substance as a drug or potion used to treat something other than disease. So in this case, we are not a drug. Exercise is not a drug, but it has drug-like effects. Okay, so exercise is not the solution to everything, but it definitely can improve and assist and help, and sometimes completely remove someone from medications at times. Is it going to repair a damaged area in the heart after a heart attack? No, but can definitely aid in adaptations that will help with functional capacity and abilities, morbidities and comorbidities, and definitely give a better quality of life after any event. When you look at pathophysiology, when you think about pathologies, you see that when and even in healthy people, or so-called healthy people, we know that the lack of oxygen versus the abundance of oxygen supply is a key factor in the maintenance of any cell and thus tissue and system and so on and so forth. That is a basic principle, and when you're lacking the right amounts of oxygen or the ability to supply oxygen, bad things happen. Obviously exercise, especially aerobic exercises, help with that, and that's a key factor in understanding our ability to help and improve one's life and decrease their chance of death. Okay, so slide 14 asks, is medicine first? And the answer is yes, no, and definitely maybe. So in that loop of exercise and its effect on medicine, and then medicine and its effect on exercise, which one comes first? I think that in the majority of cases, when people are not trained, then medicine will come in first. Naturally, something's wrong, they go to the doctor, they are assigned medications, and then we deal with it as part of our exercise prescription plan. But if someone is already working out, then I think that it would be good for the physicians to understand that and take that into consideration, and if they don't know how, they should consult a clinical exercise physiologist. Now, the sad part is that a lot of people will hear that, especially physicians, and think that we're crazy, but we're not. We know what we're doing, and in that case, definitely the exercise should be taken into consideration first. For instance, the dosage, or weaker, so to speak, less potent medication may be taken into consideration if someone has already exercised, or if they're going to exercise. All right. Let's see. All right, I'm on slide 18, and we're talking about old school versus new school. This is something that a lot of the people out there don't understand. What is the thought behind treatment? So old school would be, that if someone is sick, they need to rest. Movement / exercise, right, should not be conducted immediately. It's what I call the "or you poor baby" kind of theory or concept, whereas people after medical treatment would be rested for weeks upon weeks rather than exercise almost immediately. The old school idea was do no harm, meaning that treatment should not harm the patient in any kind of way. For instance, if you know that treating the heart is going to damage the liver, do not do that, because they saw damaging, or they perceived damaging the liver as being as doing harm. As we're modern medicine, is do less harm, meaning harm is gonna might happen. The question at hand is which treatment will allow the patient to live longer, or to live the same but with less pain. Understanding that some treatments may do harm. For instance, we have medications that often affect the liver. The liver is the target organ that will deal with all those harsh and potent components of medications, and all the effects that will come out or result from taking a certain medication. So it's likely it can happen that you're taking care of the heart or the lungs, kidneys, whatever, and the liver is being damaged. The question is, if you do not save the heart and the liver is fine, versus saving the heart or treating the heart and the liver is damaged, where would you live longer without pain? So that is in the heart, no pun intended, of the theory of do less harm, and that is definitely should be in the basis of any treatment plan, and physicians definitely take that into consideration. The same thing you could say about exercise. Okay, when we're exercising someone, we might put them at risk to a certain level, or in theory, but the overall balance is of improvement, and we need to think about that as well. We need to think about everything we prescribe, and we must not be robots and just prescribe whatever. We need to understand that, and we need to think, how do we do less harm? Okay, let's jump forward. Basically, we've spoken about a lot. The presentation kind of breaks it down, but the ideas should be clear. All right, let's jump to slide 24 and start talking about body composition. Obviously, knowing someone's fat percentage and body density and the division of tissues is very important, and has a high correlation with diseases and health. So we have developed different methods to try and assess body volume and body fat percentage, and from there understand or give some kind of prognostics. I would like to emphasize the need to differentiate between calculating, measuring, and estimating, and you should think about what are we doing. So the subfield of body composition pertains to the study and application of principles related to the relative contribution of different tissues to the overall body composition. And it's a bit tricky because numbers can be deceiving. So we we estimate body composition, and we estimate total body fat, and we're estimating one's health, and we're estimating its contribution to either health or health conditions in that person. And I'm emphasizing the word estimating because it is not a highly accurate field, but it still works, and these are the tools that we have to work with, especially us. Okay. The idea mainly behind all of these procedures is that excessive fat is not healthy. Okay. Okay. So the assumption is that excessive fat comes from a non-balanced, non-healthy diet, lack of exercise, genetic components, and basically you have excessive fat, meaning that fat is not put to use in a functional way, because we do know that there's a certain percentage of your total body fat weight or mass that is functional, and we need it. So not all fat is bad, only the ones that we don't need and start, weighing heavy on the body and its function. One of the major assumptions that is not necessarily true and causes a bias in these calculations and estimations is that mass is distributed evenly around the axes of the body. Usually the major axis used is the vertical one, and we are assuming that we are symmetrical. That is obviously not necessarily true. So you have to understand those biases. Let's see. We have different ways to take the body and look at them. So one of them would be, looking at the body and asking, okay, what atoms are most likely, to induce volume or weight, mass. So we have the atomic division, and then we have the mass division, which pertains to the percentage of the body's overall mass or weight. So first of all, we know that anywhere where gravity applies, it doesn't matter what extent of gravity, mass automatically becomes weight, right? So we know that atomically, hydrogen is by far the most common atom, but mass-wise, oxygen is in the lead, meaning that if you count the number of atoms, you'll find more hydrogens. But if you count mass, you will find out that oxygen leads the way. And this originates directly from the idea of the molecule of water, where you have 2 hydrogens for every oxygen. We can also look at the molecular division of the body, meaning that we're counting molecules rather than atoms and any contribution to mass. In that case, water, we'll look at water, lipids, proteins, carbs, DNA, etc. The fourth division option is the division to tissue. What kind of tissue do we have more than other? A fifth division is the amount of cells within every tissue. And in this case, for instance, non-human bacteria would have the highest count of cells. So when we look at the practice, at the technique of taking a certain test or measurement, a certain process, circumference, skin folds, and so on and so forth, usually what